In this episode of the ASC Podcast with John Goehle, we cover the latest updates from the ASC industry, discuss recent ASC issues and survey experiences, review a recent survey by Avanza, discuss high-level disinfection issues, and in our focus segment, we interview Jennifer Cantrell with AMSURG during the New Jersey ASC Associations recent conference, where she discussed patient engagement and how OAS-CAPHS can provide valuable information for improving patient satisfaction.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServ, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs, and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 247 of the ASC Podcast with John Goehle, recorded on May 28, 2025, from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry, and he is a highly regarded speaker on topics related to regulation, accreditation, and financial management.
So, Sue, this is another busy week for my schedule. We've had quite a number of surveys, both announced and unannounced, at Ambulatory Healthcare Strategies over the last couple of days. And even with our drop-in sessions, we've been having discussions with many of the people that drop in for our patron program on either Friday or Saturday, depending upon the week. And that's been kind of interesting just to see how active surveys are right now and the different types of experiences we have. And just a reminder, if you're a member of the Patron Program, you have an opportunity to talk to us, usually about a weekly basis through Zoom. And I'm heading off to the LUGPA Ambulatory Surgery Center Academy's conference in Scottsdale, Arizona tomorrow, where I'll be involved in 3 presentations for urologists that have or are thinking of developing an ambulatory surgery center. LUGPA, by the way, is the only nonprofit urology trade association in the United States, and I'll provide a link to the website for anyone interested that's in the urology trade.
And I know as you've been traveling around, you've been surprised in this past month how many listeners don't know everything that we do between Ambulatory Healthcare Strategies, ASC Central, and the ASC Podcast. There's quite a lot of services and information between all of those.
Yeah, and as I think we mentioned in one of our previous episodes, we had a booth this year. Ambulatory Healthcare Strategies and the ASC Podcast had a booth at the ASC 2025 conference. Yep. And we visited with quite a number of listeners of the podcast, and they were shocked at the different services that we offer between these 3 different organizations. So I thought it might be wise just to kind of mention the different services that are available through our various websites, and I'll provide links to each of the websites here. So between these 3 different organizations, we have services that range from the free podcast all the way up to, full service, ongoing retainer-based services. So, of course, the ASC podcast, as all of you who are listening know, it's free and available to anybody. And you can go back and listen to any of the episodes we've created since 2018. And, of course, you can access all that information on our website at ascpodcast.com.
And there you can you can look through what the subject was for all of those podcasts.
Right.
If you're looking for something in particular.
And as Sue said, it does have you can search, using your browser to look for anything specific. And we also have ASC Central, and I'll provide a link to that website, that offers the $25 a month patron program that we've discussed many times during the podcast, which provides you access to some information, a database of various information, as well as the usually weekly drop-in sessions via Zoom with the podcast hosts and other patron members. And then also at ASC Central, you have what we call the Premium Access Program for people that want even more help. And that includes access to all of our training programs at ASC Central. And if that's not enough, we have Ambulatory Healthcare Strategies that offers ongoing retainer-based services to assist your staff operate your organization in a compliant manner. Ambulatory Healthcare Strategies services sometimes replaces the services of some of your staff or helps organizations that can't afford or can't find high-level leaders. So again, we'll provide links to all of those various websites where you can get more information on that. So hopefully soon, next time we visit with you during our conferences, you'll be all up to date on all the different services that are available through Ambulatory Healthcare Strategies, the ASC Podcast with John Goehle, and ASC Central. So Sue, let's talk about some recent news.
The 6th annual Avanza Intelligence Hospital Leadership ASC Survey Report was recently released. This report highlights the increasing role of hospitals in ASC ownership, as well as the increasing role of ASCs in outpatient surgical care. So here are some of the takeaways from the report. 82% of hospitals and health systems now have ownership in at least one ASC. That percentage was just 41% in 2019, and it was 48% in 2023. So the growth is really accelerating in the last couple of years. And 90% of hospitals and health systems plan to keep investing and affiliating with ASCs, which is up from 71% in just that last year. The most often cited reasons for investing in ASCs were to increase outpatient surgical capacity, that's 66%. And just a note, so these percentages are not going to add up to 100 because people were able to pick, more than one. Enhanced physician relationships at 65%, respond to consumer-driven trends at 52%. Some other reasons were reducing costs, payer pressure, and preventing physicians from taking cases outside of the hospital system. And those were at 33, 25, and 24% respectively.
So this is very interesting. Again, we've always considered hospitals to be our competitors, and as Avanza study shows, they are taking an active interest in collaborating with physicians in the development and the ownership of ambulatory surgery centers. So this, I don't know if this is positive or negative. My experience with hospitals is that they often bring some unwanted complications to surgery centers because they do try to sometimes impose the hospital mentality there. Yeah, and they did mention the CONs and the problems with, so, there's that limited space, and depending on your CON laws in your state, so they do have to try to be part of that, right, if they don't want to sort of miss out. Yeah, and that is indeed one of the issues that we always see, is that many independent physicians who are looking to create an ambulatory surgery center often find that the easiest way to get into it in those CON states is by collaborating with a hospital. Yeah. But I think, definitely if you own an ambulatory surgery center, you have to, keep an active ear out for opportunities to collaborate with hospitals and recognize that is a possibility of growing the business. But also that by collaborating with hospitals, it does bring a level of complexity that many of us in the freestanding or the physician-only ownership space prefer not to really have to deal with on an ongoing basis. And I saw something in the American Journal of Infection Control about high-level disinfection of flexible endoscopes. A review of peer-reviewed articles, FDA adverse event reports, inspection documents, and government surveillance data was published in the American Journal of Infection Control. And they noted substantial bioburden and pathogens that commonly remained on flexible endoscopes after processing
using high-level disinfection. The report, which was published on April 8th, looked at processing practices and a variety of flexible endoscopes, including colonoscopes, cystoscopes, and bronchoscopes, and as well as some other ones. So here's some of the points. Dozens of outbreaks, some leading to fatalities, were linked to contaminated endoscopes. Even after high-level disinfection, they found microbial contamination and this is a broad range, but in 6 to 72% of clinically used endoscopes, including high concern organisms such as Klebsiella pneumoniae and fungi like Candida, as well as bloodborne viruses like HIV and hepatitis B and C. And according to CMS surveys and FDA reports and other previous studies, skipping or improperly completing essential steps such as immediate pretreatment at the point of care, which seemed to be really a big one, leak testing, and correct drying practices were routinely noted. Many facilities lacked oversight and appropriate training, and they noted because there's a slim margin of safety with HLD, poor practices have a much higher chance of resulting in ineffective processing than sterilization, which is a more, of course, automated process, and therefore you don't have that risk of human error quite as much. So there were many actual examples in the report of poor practices cited by CMS or the FDA, so we will provide a link. Some organizations are moving toward recommending sterilization, but at least a big takeaway is make sure to monitor all the steps in the processing and make sure everyone's following the instructions for use carefully. Some other notes were that endoscopic procedures are more invasive now than they were years ago. So when they first started, and maybe the high-level disinfection was fine for that, but you just have to be a lot more careful now. And patients are usually followed for 30 days for infection monitoring, but in some cases, these types of infections can take months to show symptoms, so we might be missing some of those. And another point which I hadn't thought of is using a still contaminated endoscope when you're obtaining clinical samples could result in false positive results. So it could trigger the use of unnecessary antimicrobials and other treatments that really aren't necessary because it's on the endoscope rather than the patient. So it's just really something to, again, I don't think a lot of people are going to move right to sterilization, but just really focus on getting all of that, that point of care cleaning and that drying seem to be big parts of this.
Yeah, I think speaking as a surveyor who watches high-level disinfecting during surveys, a couple takeaways that I would point out from this survey as well as my own experiences is making sure before the endoscope leaves the operating room or the procedure room that you make sure that you pre-treat it. That, as you indicated, that appears to be one of those indicators of properly preparing the endoscope for good cleaning. And I think the other point that I take away is the importance of good oversight, ongoing oversight in your quality improvement program, and excellent and appropriate training and documentation of that training and any follow-up on that training if you find through your competencies that your employees are not following the instructions for use. Yeah,
and if you're doing testing to make sure that everything looks good afterwards, you really have to sometimes delve into, deeper areas of the endoscope or make sure, they did say a lot of times people are testing and it looks like they're clear, but they're not checking all the areas of the endoscope.
And we know one of the big issues here is that these GI centers that are doing this or multi-specialty centers that are doing it, are in a hurry. These cases go very quickly and you need to get that endoscope back into operations. So again, I think this is a interesting survey, and it's kind of scary too, Sue, in that, and I think one of the concerns that I had there is when I'm hearing that these things can manifest after the 30 days, there's really no mechanism that we have in place for doing that follow-up.
Yeah. But something like HIV or hepatitis, you may very well not know that for years. And as I said, hopefully those are extremely rare circumstances or sort of never events, but if you can't guarantee that it's completely clean, there's definitely risk there.
Yeah, we're already seeing that sterilization is starting to become the standard of care with some of the rigid and some flexible endoscopes, especially in the urology area. So something to keep a close eye on. So let's talk about some recent experiences. Sue, one of the things that has shown up on the HHC surveys recently is the requirement to have a chemical risk assessment performed in your organization. This actually comes out of an OSHA requirement as part of the chemical safety precautions. So it is one of those questions that I ask, and surveyors are required to ask if they're doing a HHC survey, to have this chemical risk assessment. It's actually a relatively easy assessment to do. You can get, if you do a Google search for chemical risk assessment through OSHA, you'll be able to pull up an example template for that. So just make sure that you're doing that prior to your next survey, and certainly make sure your employees are well aware of this particular document. The chemical risk assessment shows a list of all the chemicals in your organization, as well as any risks associated with them and any procedures that you have to take, including the use of PPE when you're handling that particular chemical. And another thing that's been coming up recently is we're finding employees and physicians and anesthesiologists who do not have the proper CPR or ACLS certification. There are a number of organizations out there that provide CPR and ACLS training totally over the internet or totally online. And you're going to find that most accreditation organizations, and to a certain degree CMS in some of the states, do want to see documentation that there is a hands-on component to the CPR and ACLS training. I, as a surveyor with HHC, will be specifically looking to make sure that American Heart Association logo is in the upper right-hand corner of the certificate. And
it's so important. If you don't get to practice this, I mean, if you're working in an emergency department where you're coding people on a more regular basis, you might not need it as much, but there's something about having the hands-on. It's really going to make you much more prepared. And I'm wondering, did this more start up during COVID, or has it just gotten more focus on it now?
No, I think it did. I think during COVID there had to be alternatives, and during COVID, we allowed people to do the online because there really wasn't the ability to get together. But to your point, I'm most concerned about this in those organizations, such as all of our ambulatory surgery centers that, thank God, don't have regular codes. And I think that really emphasizes the importance of having this hands-on training. And Sue, brings up another point that I'd like to make too, is that I know there is a requirement for annual code blue drills. But one of the recommendations I make, this is totally consultative, is that perhaps you consider doing that more frequently than annually in those organizations that haven't had a code in a long time. Or even if you have had a recent one, just to kind of go through that exercise periodically to keep your skills up to date.
And I'm sure that if you haven't had a code in a long time, people will tend to get complacent, and those are the times when you'll kind of think, oh, this never happens here. We're okay. We're not doing really serious procedures or something, but like you said, those are the times you really need to be prepared.
Yeah, and it also brings up another interesting point. I know I've mentioned this on a previous podcast, but it's extremely important that when you're doing a code blue drill, you engage the anesthesiologists and, as much as possible, the physicians in that code blue. Because obviously the anesthesiologist is most likely going to be the person running the code blue drill. So make sure that they're included in the drills. And I had an interesting survey with a state surveyor in Maryland just a couple days ago. And this surveyor noted that if the organization doesn't have an anesthesia machine, you will need a positive pressure demand valve. Now, I have to admit, I had never heard of a positive pressure demand valve. And we had to do quite a bit of research to find this particular device, and it is on back order, by the way. So just be aware that, at least if you're in the state of Maryland and you don't use anesthesia machines in your surgery center, that they will be looking for a positive pressure demand valve. But definitely something to keep an eye on if you're in any other state, too, and if a surveyor happens to be thinking about this. And as I understand it, this really helps in maintaining the proper oxygen flow for the patient during an event.
And we just wanted to remind everybody the importance of screening for marijuana use in your patients. I know, John, you were visiting a surgery center recently, and there was a patient who woke up from surgery very combative, and it was so disruptive. So really, this is a safety issue for the patient, but also the staff and the other patients. So this is a common thing that can happen in patients who go into surgery with an altered mental state due to the recent use of marijuana. If they come in and they're currently high, I guess you'd say that those patients can wake from surgery in a violent state, and they may also require more pain medication to control their pain, so that just amps that up because they're uncomfortable. And also, of course, keeping in mind they might require higher doses of anesthetics and also could have an increased risk of airway hyperactivity. So there's a lot to consider. But, John, that was a alarming situation.
It was, and I was there for other purposes, and suddenly there was a call to the administrator and the director of nursing to immediately come to the post-op area, and I found it interesting. I did go with them to see what was going on, and the patient had come out of the anesthesia quite distraught, complaining about extreme pain. Anytime they moved him, he complained and screamed, really, and it was very disruptive to the other patients who they had to move to another area. And it took, I think there were about 3 or 4 employees that were working on and helping the post-op nurse here to take care of this particular situation. Now, when I talked to the anesthesiologist afterwards, he pointed out that, first of all, there was a heavy smell of marijuana on his ride that was accompanying him, as well as the clothing that he was wearing. So they really apparently only noticed this at the end of the procedure. But it was quite a disruptive activity, and I think it just, as you said, Sue, it brings up some very important things to remind our listeners. And one thing to make sure of is that you have a policy at the very least, or a protocol to deal with these patients, and to make sure you're asking patients about the use of any of these drugs, whether they're legal in your state or not legal in your state, and make sure that the patient understands why you're asking this specific question, that it's for their health and safety. You're not trying to get them into trouble or to stop their surgery, if it's appropriate. It's just to make sure they're providing the right care.
And I think, I was surprised when you said this, and I looked into it because to me, and I think a lot of people might think, well, it'll just relax them more. Yeah. I mean, not that it's a good thing, but you wouldn't expect it to go the opposite way almost and make them wake up violently and have more pain.
Right.
So it's important. I think if the patient knows that, they might be more likely to be more open about it.
Right. And I'm not about to say that the marijuana actually caused the problem. The anesthesiologist felt that he did, but it may have, I assume that it had a contributing factor. And everybody reacts differently to, alcohol and drugs. So you just have to be prepared for whatever that outcome is. But at the very least, make sure you have a policy or protocol to address it, and that you have a good discussion during your medical affairs committee meetings or medical staff meetings, as well as your governing body meetings, to make sure you have the appropriate policies in place. So, Sue, during the New Jersey State Association meeting a couple weeks ago, I visited with Jennifer Cantrell, and she's with AMSURG. She did an interesting session called Connecting Purpose with Stories That Ignite Our Why. Now, I'm not during our conversation, it wasn't really so much about that presentation itself, but it veered into a discussion of patient engagement and how the OAS-CAPHS survey can provide valuable information for improving patient satisfaction. And I know during the interview, I mentioned that you and I, Sue, had talked quite a bit about OAS-CAPHS leading up to it. And I have to say, we probably didn't talk about it in a positive manner because of our concerns about the number of questions. But Jennifer really had a completely different attitude here about it, and was looking at it from a very positive standpoint. And that's why I really enjoyed the interview here. So let's take a short break, and when we come back, we'll have this interview with Jennifer Cantrell. It's been a long day, and the surveyor's just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? More importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com. I'm here at the 15th Annual New Jersey State Association of Ambulatory Surgery Centers Conference, and I'm here with Jennifer Cantrell from AMSURG, and she's doing a session shortly on patient engagement. And it's so great to meet you, Jennifer. We spent about 15 minutes getting to know each other here, and I can already see that one thing we have in common is our passion for for the things we like to talk about. So please introduce yourself.
Hi, I'm Jennifer Cantrell. I'm the Director of Patient Experience at AMSURG.
Thank you. So you're doing a session on patient engagement, and maybe you should introduce AMSURG a little bit. I think a lot of our listeners are with independent surgery centers because they don't have the resources that perhaps the AMSURG out there. But we do have listeners from those also. But so for our listeners, help them understand where you come from in your company.
Sure. So AMSURG is a ambulatory surgery center management company, and we work with about 250 some odd centers across the country. We have centers just all up and down the East Coast, out west, and everywhere in between. So my job is to help these centers with patient experience. We do, obviously, the OAS-CAPHS survey for patient satisfaction or patient experience. And my job is to help make sure that not only are the technical pieces of that working and everybody is compliant. I hate that word, but it's a CMS mandate. So therefore we have to make sure that everybody is doing what they're supposed to be doing in terms of ensuring that the data is uploaded to our vendor and that that information can then get pushed to CMS, because there are some very real ramifications if a surgery center is not doing these surveys. And so we want to make sure that everybody is doing what they're supposed to be doing so that they can not be penalized. There's a significant penalty that comes along when a center is not doing the OAS-CAPHS survey. But the bigger part of that is that we really want to learn about patient experience through the stories that we get from the data and the comments that patients are sending back. And there really is a gold mine of all of the amazing things that we're hearing about, the great work that's going on at our centers.
So it's interesting that we talk about this, as our listeners well know and are probably very tired of, is we've been talking about OAS-CAPHS, the end of last year, actually well before the end of last year, leading into it. But interestingly, as I'm talking to you, we've spent very little time talking about what you can do with the data. We spent more time talking about the ramifications, as you said, of potentially losing that 2% off of your increase in your fee as part of your Medicare quality reporting program. And but you bring an interesting aspect here, and I got to admit, I think sometimes so many of us are frustrated with this requirement. We loved our patient satisfaction surveys that we created ourselves, that were geared toward our organization, and now we have to switch to this. And I think I will take the blame for perhaps focusing so much on what we're losing as opposed to what we may be able to gain from it. And I think one of the things you're going to talk about in your presentation is the rich amount of data that you can get from them. So let's start by focusing on what is in that, the OAS-CAPHS program, the information that you're going to get back that can really be a gold mine for you.
So one of the things that I think is really interesting is that we have this survey tool that we're being told we have to use. Mm-hmm. There's no wiggle room. Depending on your vendor, you can absolutely add additional questions, but we can't remove any of the questions. We can't change the questions. There are certain questions that have to be asked. And there are a lot of patients that sometimes that rubs the wrong way. We get comments all the time about, why did you have to ask the demographic questions? Why is that important to you? What difference does it make what my ethnicity is? So there is that aspect of it. And then there's the other aspect that I think one of the biggest things that we hear is that many patients respond to the survey not about the surgery center itself, but more specifically to the practice. And that's a huge distinction, and patients, for whatever reason, are not able to see the difference in those two things. So I say all that to say that we've kind of been given this game, and we have to play by these rules. My job is to help our centers figure out the best way to use the data as it comes back to be able to get some really good insight into what's going on. We know that this might not be the very best way to collect our data. To your point about the homegrown surveys that many of the centers really liked, I have had multiple centers say, why can't we just go ahead and do these too, or instead of, and unfortunately CMS just doesn't allow that. So the way that I look at my role is really that here's the rules, let's figure out how to play the game. And one of the best things that I can offer from that is that there is a wealth of information. There are certain questions on that survey that are very, very telling. Across the board, based on the work that we've done with our survey vendor, we know that 2 of the questions are very specific to behavior standards. And so one of those is staff, and the way that it's abbreviated on the reporting is staff ensured you were comfortable. That question actually reads as doctors and nurses ensured you were comfortable. And when you start to dig in and think about what that question really means, it's not just about did they make sure that I was warm? Did they make sure that I had a pillow? Did they make sure that my positioning was correct? It's also about the emotional and mental comfort too. And so how are we tapping in with our empathy and our compassion? And did we recognize that that person was really, really nervous about this procedure that they were getting ready to have? And so there's a lot of depth to these questions. And when you start to be able to zone in and really look at that stuff, it makes a big difference in the way that you're providing your care. Additionally, we have all of the anecdotal information that comes back with the comments that patients leave. Sometimes patients will go so far as to include additional attachments. I just got one yesterday, actually, where they didn't have enough room to write in the comments section, so they sent more information in. And so our vendor goes ahead and sends that to us, and it gives us even more insight into what was going on. We have the ability to break the information down to the physician level, so we can even look to see, okay, this batch of patients, when I look at those questions that are very specific to the physicians, maybe it's the pre-op instructions, which arguably is one of those things that our centers will say is something that they don't have any control over. Most of the time, that's true. Most of the time, that falls on the practice, and yet on the survey, we're getting questions about it. When we're able to break that data down by the individual physician, and if we've got 5 doctors, let's say, at a particular center, and everything else is equal. The staff is the same, the layout is the same, the procedures are the same, and you can see a wide variance in the patient scoring of those physicians. If Dr. Jones is scoring at the 75th percentile, where Dr. Smith is at the 99th percentile, that's a huge difference. Mm-hmm. And it makes me question what is so different about what's going on. And then you can break it down into the individual questions and say, okay, wow, look at the difference in the way that the question about did doctors and nurses treat you with courtesy and respect, and Dr. Jones is blowing it out the park, and I probably got my doctors mixed up here, but the first doctor is doing really well with that. The second doctor is not doing very well, but the staff is the same. You start to be able to see that those physicians are really what the difference is there. The comments are incredible. I'll tell you a quick story. I got a phone call actually from a patient's sister who was very remote from her sister. They lived in different states. Her sister had had a stroke years before and was non-communicative. She came into one of our eye centers and had cataract surgery, and the sister wanted me to know that it was so life-changing for them, because when she did a FaceTime with the patient later that day, that it was the first time that she recognized that the patient could see her clearly on FaceTime, and she saw her sister light up, and it really made a big difference. Secondarily to that, once her sister got back to the the center where she was living, the nurses now had the ability to communicate with her because they could use a communication board, and the sister could actually identify what her emotions were, as opposed to the nurses had up to that point only been able to communicate based on the way that the sister cried. Because if she cried one way, that meant she was hungry. If she cried a different way, that meant she was uncomfortable, whatever. But now they have this whole new world where she was able to point, I'm angry, or I'm sad, or I'm happy, or whatever, I'm hungry, whatever that is. So it completely changed the way that they were able to see things, literally. Mm-hmm. So we hear those stories, and those just fundamentally, like, I get goosebumps about that one every single time I tell it. And that's been a year ago since we got that story in. So we just get these amazing things. Other times we have lots of recommendations that come in. And so anything that is considered to be feedback, we want to look at those, and we want to see if we are able to identify trends and say, oh my gosh, we had no idea that there was a problem, so much of a problem with the noise in the background. Like, we come to work and it's the same. This is basically our second home. We live here. So things start to fade into the background for us because it's just a part of our atmosphere, our environment. But for somebody who comes in and this isn't where they live, if you will, then that's going to be quite jarring to come in and to be able to hear what's going on down the hallway. Maybe we need to look at investing in some white noise. So there's a lot of things that we can get from them. Additionally, I have gotten to the point, I've done this work now for almost 30 years, and I've gotten to the point where I can look at the data, just the data, and I can pretty much identify what's going on when I see a dip in the scores. Almost inevitably, it's because there was some change with the staffing, which then goes back to the importance of being able to tie your employee engagement scores with your patient experience scores. Because when we think about how we define patient experience, it's when you have high quality, safe, compassionate, equitable care presented in a patient-centric way, but it really has to be built on a foundation of engaged, resilient care teams. And it's across the continuum of care. We are a small part of that continuum of care, but a very important part, and a part that's growing exponentially these days. So it's really important to keep that in mind. It's important to have a well-defined idea of what patient experience is. It can't just be about, oh, well, it's about making patients happy. That has always driven me a little bit crazy when I hear that phrase, because, yeah, we would love for everybody to be happy. But based on their diagnosis, based on the procedure, there is always going to be an element of unavoidable suffering that goes along with this. And so when we can focus on the avoidable suffering, the explanation of delays, the ensuring that patients' comfort levels are achieved, not just from a physical standpoint, but again, that empathy and that compassion, we're going to go a long way with it. But I want to circle back again to the importance and the link between employee engagement and patient experience. Because if you do not have a strong foundation of engaged employees with strong leadership, you will never, ever be able to get where you want to with patient experience. You have to have that in place. I can see that in the scores. I've called centers before and said, hey, what's going on? I just noticed that there was this big drop, and it may be that there's a physician that's getting ready to retire. And it could be either way. It could be that people are really sad that he's retiring, or they're really glad that he's retiring. There may have been a change in leadership. There may have been a change at the front desk. There may have been, we see a dip in scores in December because we have higher volumes, and we have a lot of staff who are out on vacation, taking time off to be with their families. So we have higher volume. Maybe we have contract employees that are coming in. There's almost always a dip nationally. There's almost always a dip in December with the way that our scores look.
It's interesting, as I'm listening to you talk, one of the themes that we've had here with the New Jersey Association and with the pre-conference yesterday, I know you didn't have a chance to do it, is that interconnectivity between the different elements in the organization. And just before I interviewed you, I interviewed my friend Darren Smith. He and I have been around a long time, and we've known each other for a long time. And we talked, we both did a session yesterday independently on quality improvement. And one of the things we try to do is connect the dots. You know, how can quality improvement feed back into, financial and operational efficiencies? And this morning I was doing a session on strategic planning. And one of the things that I was talking about is the importance of hiring the right people and including that in strategic planning. As I'm listening to you,
here's another point of connectivity is, make sure that as you're looking at those patient satisfaction scores, you're taking that information back as you're making hiring decisions and as you're training the people you're bringing. It doesn't stop at the hiring. It never stops. You should be training your staff and using educational opportunities to go back and look at this data here. And I just love what you've been talking about. Clearly, the two of us are very passionate about our respective areas, but there's so much interconnectivity, and sometimes I think we spend too much time in our silos. You might be engaged in, making sure that the OAS-CAPHS data is analyzed properly and you're taking appropriate actions. But are we always talking? Are we always talking about the strategic plan? When we're hiring people, are we taking that information and asking the types of questions of the new hires that are going to hire people, assure that we hire people that are going to minimize those complaints or to maximize that patient engagement and satisfaction? And I love the fact that you talked about it's not about making sure the patient was happy, because they're not going to be happy. I'm not happy, going to the doctor. I don't think any of us want to be there. But it's making sure that they have an experience that is going to be appropriate for whatever their situation is. If you wouldn't mind, why don't you talk a little bit more about that interconnectivity between your satisfaction results and the hiring decisions and the training of the staff?
You're exactly right. There is absolutely that connection, and that connection and the ability for the people that you put into the positions that they're in at the centers is really critical. And it starts, and this is another hill that I will absolutely die on, is it starts with who you put in your front office. It is not just about the clinical people. That front office person or people, they are the first people that they see. And it is so important. And unfortunately, those positions tend to be lower paid. They tend to be more transient. It's very difficult to get the kind of people into those roles that you want to hold on to. When you find them, you need to do everything you can to help, because they can make or break that entire experience. You have people who are coming in who are terrified. You have people who are coming in who have been here multiple times, and this is no big deal to them. Either way, the people that they see when they first come in need to be helpful. They need to be compassionate. They need to be able to make that connection at the very, very beginning. One of the best things that I've seen, my dad was a patient at a large teaching facility in North Carolina. And so we had to have some work done. We went to visit the doctor. And when I walked in, there was a bank literally of about 20 different receptionists or registrars. It made me smile, because what they had done, all these people are behind a computer. You can't really see them, but every single one of them had a word cloud that had their name in the middle of it. They used their favorite colors to have the words that described them. And they had gone to their colleagues and said, hey, tell me about Jennifer. What do you know about Jennifer? How would you describe her? And so the words that their colleagues used and the words that they would want to be used about them, they put into this word cloud. So when I walked up and Gloria was our receptionist, I knew that she loved food shows, that her favorite thing to do was play with her dogs, that she has kids, and that her favorite colors were blue and purple. Wow. And it was amazing. And it was just that little bit of connection. Gloria didn't need to do anything extra. I mean, she did. She was amazing. But it gave me some things that I could then say, oh my gosh, what's your favorite cooking show? Right. It was really, really cool. And so I have taken that best practice back and have shared it like crazy, because I just think it was an incredible, incredible thing. But it's finding those right people and making sure not only are you hiring for fit, you can teach people how to enter in information into a computer. You can teach people clinical skills. You cannot teach them how to have compassion. You can't teach them how to be empathetic. You have to look for those things. Then you have to continue to foster it. You have to monitor it. You have to set behavior standards. It's one of the biggest things that I talk about right now is, what are you allowing to continue? And what are you fostering? How are you leading by example? We all have off days. I'll tell you about one of mine recently. I was It was at the end of one of my days. It had been a Monday. I'd had a long, hard weekend, amazingly. It was like there was a lot going on. I was tired when I got to work on Monday. It was at the very end of a Monday, and I did not show up the way that I wanted to in a call with one of our center administrators. And when I got on the call, and it was somebody that we have been working with, and so I was trying to lighten the mood, but my tone did not match my intent. And so when I said, okay, so tell me what you've done since our last call, that did not come across the way that I wanted it to. In fact, it came across as Jennifer is kind of attacking me. Now, she'd never said that, but as soon as it left my mouth, I knew that it didn't land the way that I wanted it to. And it bothered me and bothered me and bothered me for 2 weeks until I was able to get back on a call again with this center leader. And I said, I just need you to know that is not how I want to show up. I want to show up in a way that no one ever feels like meeting with me is punitive. Everybody is excited about meeting with me, that they feel like they are supported and that I am here to help them, that I am not here to monitor and do quality checks. Obviously, that's part of my job, but I don't want to come across that way. And so I recognize that, and I tried really hard to fix it. Now, when I apologized to her later, she said, oh, I didn't even notice. So
I was going to say, did she even notice it? Yeah.
I had this in my brain this whole time about how crazy it was. But it also goes back to one of the things that we do is we offer monthly sessions that anybody can join, that we provide them with whatever feedback I've gotten that they need more support with. So I can help with that. But I encourage center leaders to do employee rounds, which are not, it's just a check-in, making sure that they know about their teammates, making sure that everybody understands, why do you come to work every day? What is it that drives you? Identifying what your why is a huge part of it. And do you share that with your teammates? So making sure that those kinds of conversations are happening, that you have standards of behavior, what's acceptable, what's not acceptable, and that not only are you holding them accountable, but that they are holding each other accountable. And people are allowed to have bad days. That happens. And they're allowed to, everybody's normal. Everybody is human. But it's recognizing that, and maybe it's that then everybody else steps into the gap for them. So,
Jennifer, this has been wonderful, and I have a feeling you and I might be talking again soon, because I think it would be great to actually have you on one of our conferences too, because I think this is an important thing. What I really love about this conversation is we're taking something that, quite frankly, a lot of us are not. I liked our old satisfaction surveys, but you've really put a very positive spin on it. And I do want to remind our listeners, though, as we've talked about before, remember, you are exempt from the program if you do less than 250 fee-for-service Medicare cases per year. But you do have to monitor that. Remember that you don't have to ask for an exemption. Medicare automatically knows that, but you need to make sure you know what those numbers are. But what I think is interesting, Jennifer, you pointed out, is that you're exempt from it. It doesn't mean that you don't have to do it. You might be able to voluntarily do it. And I think you've kind of proven that there's some very positive things that can come out of it. Again, thanks so much for your time.
Thank you so much for having me. I look forward to continued conversations.
Very good.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff and other events in the ASC industry.
So the Gulf States Conference, which includes Alabama, Louisiana, and Mississippi, have a conference on June 11th through the 13th at the Ritz-Carlton in New Orleans.
The Texas Ambulatory Surgery Center Society's conference is June 23rd through the 25th at the Omni Las Colinas Hotel in Irving, Texas.
And I'm going to be there with one of my staff members. We have a booth there this year, which is the first time we've had a booth there, so I'm very excited about going. And the Florida Society of Ambulatory Surgery Centers annual conference and trade show is July 23rd through the 25th, 2025 at the Hilton Orlando.
The California Ambulatory Surgery Associations conference is September 3rd through the 5th at the Sheraton San Diego Resort in San Diego, California.
And I'll be attending that conference. I'll be doing a pre-conference, preparing people for the CASC tests that they're going to be administering at the conference, as well as doing a special podcast from there.
And the Atlantic States ASC Conference and Trade Show is October 2nd and 3rd at Embassy Suites by Hilton, Raleigh, Durham, Research Triangle in Cary, North Carolina.
And the New York State Ambulatory Surgery Association's annual conference will be held October 6th through the 8th at the Desmond in Albany, New York. And I'll be speaking at the conference. And, of course, as always, we'll be doing a special episode from there.
And the Oregon ASC Association's annual conference will be October 9th and 10th, 2025. We will have more information coming shortly, and John will be speaking at the conference, and we'll do a special episode there.
And the Joint Commission Ambulatory Care Conference is November 5th through the 6th, 2025 at the Crowne Plaza Chicago O'Hare in Rosemont, Illinois.
The Washington Ambulatory Surgery Center Association's 2025 Annual Education Conference and Trade Show is November 6th and 7th, 2025 at the Tulalip Resort and Spa in Tulalip, Washington. John will be speaking, and we'll do a special episode there.
And the Colorado ASC Associations Conference will be held November 13th through the 14th, 2025 at the Denver Marriott West in Golden, Colorado. And I'll be speaking at the conference, and again, we'll be doing a special episode. Sue, I think we have a trend here. We have a lot of upcoming conferences that I'll be at, and we'll be doing special episodes. Yes. And don't forget, on-demand versions of the ASC Director of Nursing, ASC Administrators, and the ASC Business Office Managers boot camps are available on our sister website at asc-central.com, and I'll provide a link to that. And as we've mentioned earlier, I do want to remind everyone to become a patron member of the podcast. Don't miss out on the benefits of joining the program, which is available at asc-central.com. This comprehensive membership platform is your go-to resource for all aspects of ASC regulatory and accreditation, compliance, operations, and financial management. And it's designed with the busy schedules of administrators, nurse managers, and business office managers in mind. By becoming a member, you gain access to regular Zoom sessions, typically held weekly, where you can engage with other patrons and our podcast team. But that's just the beginning of our services. Your membership unlocks a wide range of resources, including virtual conferences such as the Credentialing Conference and the Conditions for Coverage Conference. And you'll also find valuable tools like sample policies, procedures, forms, and our highly regarded fire and disaster drill kits. Your support helps us to maintain and grow the podcast, covering essential costs like research, travel, equipment, and production. To learn more and to become a member, visit asc-central.com.
Thank you for tuning in to this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community, and be sure to subscribe so you never miss an episode. We appreciate your feedback and suggestions for future topics. Reach out anytime at comments@ascpodcast.com.
And a special thank you goes out to our incredible team here at the ASC Podcast, which includes our sound editor, Susan Cronkite, executive producer, John Goehle, and our committed research team of Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Calritis, Jim Masters, Amy Cronkite, Lori Rodericks, Kathy Foti, Donna Macchio, and Christina Norman. Their hard work makes this podcast possible. Our theme music is from Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast platforms. Thanks for listening, and we'll see you in the next episode.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.